Hi everyone, this is Dr. Oliver. So this is the second part in our pain series, and we're basically going to talk about how to assess pain in the palliative care or in the palliative and hospice patient. The objectives for this lecture are as follows. So one, we want to understand how to properly assess pain, and two, we want to understand how to assess and recognize pain in the hospice and palliative patient. So how do we assess pain? I'm sure you guys, in your current assessments as nurses, you assess pain. And as a nurse practitioner, you will assess pain. We will ask if anybody's hurting. We will ask if, if they are, to rate their pain on a scale of 1 to 10. We will ask them, what type of pain it is. How does it feel? Is it happening like this or happening like that? With the palliative and hospice patient, a lot of the times we we will of course include those questions. So it's a very similar pain assessment. However, we add even more questions to it because if you've listened to the previous lecture, we know that there are a lot of factors that play into a person's pain and how that relates to their quality of life and how they define it for themselves. So pain it's known as the fifth vital sign, and it really should be incorporated in an assessment like that. So every patient that you come in contact with, whether they're a hospice patient or a palliative patient, you really need to be addressing their pain or at least acknowledging the fact that they could have pain. So we need to ask them, because approximately about 70 million Americans report persistent or intermittent pain annually, and typically that's improperly diagnosed due to an inadequate assessment. And a lot of the times what that stems from is because people never even ask them. So there's a couple different pain acronyms that hospice and palliative care providers will use. We're gonna use one of the more common ones, and one of the ones that I typically like to use in practice when I'm seeing palliative care or hospice patients. So we'll go through this. Each slide will go through what each letter means. So the first one is P for provoking. So we want to ask them what brings it on, what makes it better, what makes it worse. An example of this is that, they might say, well, twisting causes my low back pain to start and makes it worse, but resting makes it feel better. Now, as you know, it's very typical as far as other pain assessments. So this is not just specific towards hospice and palliative care, but it needs to be included no matter what type of patient you're seeing. The next one is quality. And this one is important because we want to try to pinpoint exactly what type of pain they're having, whether it be somatic, visceral, neuropathic. We want to make sure that we can pinpoint that because that really will be a driving factor for what management options we choose. So we want to ask, what does it feel like? Can you describe it? They might say, my low back pain is sharp when I'm twisting, but it goes away when I'm resting. And those are things that need to be documented appropriately. The next one in our acronym is R for region. So we want to know, where is it? Does it spread anywhere or does it stay there? So is it radiating? So for example, they're complaining about this sharp lower back pain that is more prominent when they're twisting. They might say, well, it's especially located over here near my right SI joint, which, I mean, you won't have patients say SI joint a lot of the times, but they'll say my right lower back. And so, you have to determine, is it more flank pain or is it more specific SI joint pain? Because a lot of people with degenerative joint disease will have specific SI joint pain. And so it's important that you're able to document that region of where it's at. The last letter in our acronym is V for values. So this is one that may be a little bit different from the pain assessment that you're already doing with your patients, whether it be in your clinical site or at your nursing practice right now. But values is something that is extremely important when you are assessing pain in the hospice and palliative care patient. So we want to ask them, what is your goal for this symptom? What's a tolerable level of pain for you on a scale of 1 to 10? Are there any other views or feelings about this symptom that are important to you or your family? And that can be, are you Are you afraid of showing your family that you are in pain? Is it important to you that we get your pain controlled enough so that other people don't know that you're in pain? Is it important that we get your pain controlled enough so that you can go on walks with your wife at night? Is it important that you get a full night's worth of sleep? And to do that, you need to have your pain at a certain level. These are all questions that we need to ask. A lot of the times, pain will cause a lot of anxiety. So, do we need to get your pain to a certain level so that we can get your anxiety controlled? A lot of the times, they don't necessarily need medication for their anxiety; they just need their pain controlled. So, it's important to know this. It's also important to know if a patient really expects their pain to be taken care of completely, because a lot of the times when a person says that, although that would be everybody's goal. A lot of the times in chronic pain, especially in chronic disease, we're not going to get rid of their pain completely. And so that's a very important time. And this part of the acronym opens up a discussion and opportunity to educate patients on that, hey, you have this chronic disease. There's things that we can do to help you, although we may not get your level to a 0. So that's why it's important for me to know what is an acceptable level for you. What level can you function in your normal daily life, if it was at that level? And so those are important questions. Okay, so we're going to go back to that concept of total pain. And that concept is so important for palliative care and hospice patients because, as we talked in the previous lecture, there's lots of factors that play into total pain. So, and this is actually a little bit different picture because I wanted to show you that there's so many different factors. So a lot of them, their physical well-being, their social well-being, their spiritual, their emotional well-being. That is a good place to start with total pain. This one right here that I have is a little bit more focused on emotional pain, and I did that specifically because a lot of these patients that come to you and they are on palliative care or hospice, they will either have depression, anxiety, anger, or they'll have both. And a lot of the times, or they'll have all three, or two of them, or just one of them. But they play into the person's total experience of their pain. And so it's important to make sure that we understand why they are experiencing that emotion. If we can control that emotion, so if we can do other interventions like maybe get them in with a counselor, or even just us sitting down and actively listening to them and just allowing them to vent a little bit, if that helps their pain, that's a part of their treatment plan. And so that's important, that we take the time to figure that out. We figure out really what do they need at their core. So, this total pain, it affects their quality of life, and we want to know exactly how and how we can fix it. So total pain, it causes more stress for the patient and their family. A lot of the times the family is so overwhelmed because their family member is not acting the way that they typically do, that they're not able to see all of these other pieces. And so that's why it's important for us to be able to recognize them. Total pain, it's really hard to properly assess due to their disease progression too, because if they have say they have brain cancer. Brain cancer is actually, it's a very difficult type of patient to take care of because each one is different. They're very individual in their symptoms, although we know the majority of them will experience issues with depression or anxiety or both. Sometimes they get very paranoid, and it's just because you have that increase in ICP pressure. You have, this tumor in their brain that's taking over a lot of space, and it changes their personality. So a lot of the times that's more of a progression. They may be depressed, but it may not necessarily be because they lost a social position or they lost a role in their family. It might just be because of their disease progression, because it's changing their personality. So it's important that you understand that when you're asking your questions so that you can tailor your questions appropriately. And as a palliative care or hospice provider, it's not expected that you find out all the answers. The nice thing with palliative care, like we talked about in previous lectures, is that palliative care and hospice takes an interdisciplinary approach. So you're going to have other people on your team that are also doing their own investigation, and that's why there's frequently interdisciplinary meetings. We would have one every week, and we would after a while, we had so many patients we couldn't go through all the patients on a weekly basis, but we would go through all of them every month at least. And that's important because you can get input from other people, and who knows, maybe that patient that day was having a better day, and they were able to give more information to, say, the social worker that visited that day rather than you that visited them 2 days ago. So total pain really has to have an interdisciplinary approach in order to be treated appropriately. I wanted to briefly talk about the hospice patient with pain. I'm not sure if any of you, I think a couple of you I've heard that have worked around hospice patients. If you have, you are aware of this final death phase that a lot of them can go through. A lot of the times they can experience some terminal agitation. Sometimes they'll get a burst of energy, and the family will say, "Oh, they're getting better, they're getting better," when really it's just kind of that final phase that they're entering into. So it's common for patients to become more confused in the final stages of death, and they don't have to necessarily have a dementia diagnosis. So it's important during this time that we make sure their symptoms, especially pain, is controlled, because they can make that stage of death so much worse if it's not controlled. So a detailed pain assessment needs to be done, and it needs to involve the family. It needs to involve other members of the interdisciplinary team. Because death in general is stressful, and as I said, pain will add to that stress and poor quality of life, even though they may have just a couple days left. We want to make sure that they have the best quality that they can have, not just for them, but also for their family too, because it's hard to see a family member go through that. Now, I just want to introduce this topic to you because this is a whole nother big topic that we could go into. But we call them clusters. And when providers are taking care of palliative and hospice patients, there's different clusters that they can be going through. One of the most common clusters is fatigue, sleep deprivation, pain, and depression. So if you look at this picture over here and you imagine a circle, all of them are interconnected. So if we increase one, it's going to increase the others. If we decrease one, it's going to decrease the others. So a lot of the times, and we'll talk about this when we get to the medications and treatment plan for pain, but a lot of the times when we are treating pain, our goal is not just to treat their pain, but also to treat other factors that are increasing that pain. So, for a person that is having a lot of neuropathic pain, and we're having a hard time getting it controlled, it's causing a severe amount of depression. However, we're not sure if the depression came first or if the neuropathic pain came first, but we just know that both are out of control. For this person, they would be very appropriate to try some Cymbalta, because we know that Cymbalta will help with their depression, but it will also help with their neuropathic pain. We also know that if we schedule their Cymbalta to be taken at night, it's also going to help their sleep, because more than likely, if they're depressed and they're having pain, they're probably not sleeping well. So we just have this whole big cycle going on here, and we have to figure out how to break the cycle. So sometimes you can find drugs that'll treat multiple symptoms, and you'll play off of their supposed side effects. Other times you might have to do a couple of medications, but our goal is to treat that cluster, not just one individual symptom. We want to treat the cluster, and that's how we're going to be able to give that patient the best quality of life that they can. So this specific pain cluster, is what we call it, is estimated to occur in about 25% of advanced cancer patients. So keep that in mind. This is a very common one. The symptoms will have a synergistic effect on each other, which means that if one goes up, another one goes up, or down, the opposite. So improvement in that one symptom, or in the improvement in one symptom, will improve the others.